I'd like to welcome you all on behalf of the McCaig Institute for Bone and Joint Health, as well as the Arthritis Society, to the 2017 Wood Forum on Shoulder and Elbow Health. Just a few housekeeping items. The bathrooms are located behind me over there. There will be photos, and today's session will be recorded. There is complimentary internet. The Wi-Fi is AIRUC guest. And you have to register with your cell phone number. Yeah, the AIRUC guest. And then you can, you need to register with your cell phone and email and accept the terms to receive the password to log in. But with that said, let's turn off all the cell phones, put them into silent. If you find yourself uncomfortable sitting for long periods of time, feel free to get up, walk around during the presentation to stretch your legs. I hope you've all had a chance to enjoy the refreshments. For those of you that have booked a full day ticket, lunch will be available at the conclusion of the program and will be available from 12 to 1. So I don't normally have to introduce myself, but my name is Jonathan Cornish. I played football for the Calgary Stampeders for a long period of time. Yeah, I think like many of the people in this room, 20 years of football, it makes your joints not feel too hot. So I know how you guys feel. I played football for a long period of time. We won some Grey Cups. I got some personal awards, but it was really through football that I got introduced to my true passion, which is charity. I'm heavily involved with Woods Homes, the Children's Hospital, and the Calgary Foundation, and I really just like giving back. You know, for me, definitely there's more pleasure in giving than receiving, and this applies to advice, volunteering, and medicine. So, how many people here have had shoulder or elbow pain? Oh, well, welcome to the shoulder and elbow pain symposium. And how many of you couldn't raise your hand? You could just nod your head because of your elbow or shoulder pain. So reaching for the glass on the top shelf, combing your hair, or like reaching for the glass of ice cold lemonade. These are all things that we take for granted. But once you have a torn rotator cuff, busted elbow, fractured arm, or arthritis, these simple tasks aren't things you can easily accomplish. You become keenly aware of how important good upper body mobility is. I myself, as I made reference to, have had to deal with quite a few different ailments. I actually have a nice little selection of different things I can talk about. Today is upper body mobility. So I had this one football game, and normally, the coaches and I were always very much on the same page. But just for whatever reason, my running backs coach he really didn't like the defense of the opposing team, and he really wanted me to truck them. Like when I say truck, I mean go after them. Listen, I played football for 20 years, but I don't like hitting. I just don't like hitting. And the coach was telling me to hit these guys. So I go as hard as I can. I want to be coachable. I want to listen to my coach, and I go after these guys. And in the process of that, I dislocate my shoulder. I was on the ground. I've always had a pretty high pain tolerance, so I didn't really feel like anything was wrong. But it's like, yeah, what's going on? I sort of had my arm out. My buddy tried to help me up, and it was like a noodle. So it's just nothing attached. I popped it back in and played a little bit more. But then I realized it wasn't the best thing for me to be doing. Luckily, the following week I had a concussion, so I didn't need to play with a broken shoulder anymore. So I've also had swollen elbows. People have had bursitis here in this room, I know. I actually learned that it was called Popeye elbow. I don't know if you guys remember Popeye. Huge forearms, and he had this big bump right here on his elbow. That's what I had on both of my elbows. I also broke my hand. That was actually a very educational experience. You do so many things with your dominant hand. And then, you break your hand and you're forced to become ambidextrous. I know that's one place I was very proud of myself was the bathroom in that regard. Fortunately, for people like me and for people like you, there's people that spend their entire careers focusing on how to keep us moving. Today's Wood Forum is an initiative supported through the Wood Joint Research Fund, created by Dr. John and Ms. Christena Wood. Their picture's just over there. And it is now carried on by their daughter, Dr. Donna Wood. Donna? There. Let's have a big round of applause. These forums are designed to bring the public and researchers together to discuss the impact of bone and joint diseases and injuries and learn about the latest and cutting-edge research in the area. Actually, a recent study I just became aware of from the New England Journal of Medicine reports that 9 out of 10 doctors agreed that 1 out of 10 doctors is an idiot. So I'm sure you'll have lots of questions throughout the morning. Let's save the questions to the end. I'll just say this now. Personal medical questions are best reserved for asking your own personal doctor. This isn't the forum for talking. Let me do all the talking about the personal medical issues. So let's save the questions for the end of the panel, and let's get started with our speakers. So first off, we have Dr. Kevin Hildebrand, an orthopedic surgeon, researcher, and deputy director for the McCaig Institute Bone and Joint Health. Kevin is a professor in the Department of Surgery at the University of Calgary and the chief orthopedic surgery for Alberta Health Services, Calgary's own. His clinical and research specialty is the elbow, and specifically how to prevent stiffness after fractures and post-traumatic contractures. I want to learn what contractures are. But first, he is here to welcome you on behalf of the McCaig Institute. Kevin?
Thank you, John. I want to thank everyone for attending today, the Woods Forum. I'd like to welcome you here on behalf of the McCaig Institute for Bone and Joint Health. I'd also like to personally thank Donna Wood and her family for the sponsoring this important event for us today. All right, how does the slides go forward here? So the Bone and Joint Health Institute, the McCaig Institute, our vision is to lead in the improvement of musculoskeletal health for patients across their lifespan through research and education. The McCaig Institute at the University of Calgary is home to some of the world's top researchers and physicians working together to improve prevention, early diagnosis, and treatment of bone, muscle, and joint conditions. What sets our institute apart is that we have researchers and physicians from many different disciplines working together to find solutions for bone and joint health conditions. These include basic scientists, bioengineers, orthopedic surgeons, rheumatologists, radiologists, physiotherapists, kinesiologists, and community health experts. Our researchers work in 4 key areas to advance our knowledge in the health. This includes osteoarthritis, rheumatoid arthritis, osteoporosis, and joint injury. Within these areas, we're working towards preventing disease and injury. We have researchers conducting work on movement assessment, developing cutting-edge imaging techniques to predict disease before it happens. We even have a study looking at the effects of vitamin D on bone health, and this picture here is our Institute Director, Dr. Steve Boyd, with a patient and a CT scanner in the background. We're also very involved with sport injury prevention in soccer, hockey, and other disciplines, which is an important focus for our institute. We also have a team working on the development of tests that will diagnose disease early and accurately. This includes biomarkers and refining of imaging techniques. And we're working on developing new treatments for the disease. This includes developing safe and effective injectable and stem cell therapies and conducting clinical trials. One of those clinical trials is what I'm going to be talking to you about next. So this is the research that I've been working on as part of a member's group. Title is Preventing Stiffness After Elbow Injury, or Why Can't I Touch My Face? So we're going to cover 4 topics in my presentation. We're going to define elbow stiffness, discuss a little bit of the surgery that we'll do sometimes to reverse the elbow stiffness. From some of our research on this work, we'll be developing our underlying causes of the elbow stiffness, and then some clinical studies that have come out about this research. So this is a person that was in my practice, a young person, about 12 or 13 years of age, had a fracture of her elbow. And we can see on the outside images, those are the x-rays after surgery. There's been 3 wires placed across the humerus. The fracture is, can you see me pointing at it? No. Let's see. I don't have the pointers. The fracture is right about where the wires all cross. And on the outside, you can see it looks kind of white. There's a splint that's been used. So this person's been treated with immobilization for about 6 weeks. After they come out, they work on physiotherapy, but unfortunately for this person, about a year later, the middle images show the limitation in the motion. This is what we call a joint contracture. So on the top, we're trying to straighten the elbow, and we can't straighten the elbow out. And at the bottom, we're trying to flex the elbow, get the hand towards the face, or I can't touch my face, doctor. I can't do a tie. I can't put my earrings in. Can't brush my teeth. So this is this entity that I'm interested in. Probably about 10 or 15% of elbow fractures end up in this scenario where we have to consider doing some surgery. And this is sort of an example of a different person though, under anesthetic. So we're trying to see if there's any improvement in the motion, but they still have the limited motion on the top 2 images, so can't straighten the elbow completely, can't bend it completely in the top. And then after we do our surgery, we have the elbow almost straight and almost bent. So when I'm doing the surgery, I'm trying to figure out what is the structure that's limiting the motion and how do I change that. So on the left is an image of the elbow, and that's looking at the elbow from the side, very similar to how we're seeing the pictures on the right when we're looking at the elbow from the side. So going from the outside to in, I'm thinking about, well, what might be limiting the motion? So on the outside is the skin. So occasionally people will have burns or other issues, scars that are across the joint that don't allow it to straighten. The next layer in, where most of the gray area is the muscle, and in some of the muscle we can see some of the tendon. So these things can limit the motion if they're stiff. And then the area that I've been working on mostly is this little structure that's right here. It's called the joint capsule. It's very similar to ligaments. It has the same building blocks as the ligaments. Ligaments connect bones together. The building blocks are organized in a little bit different fashion, but suffice it to say it's like a ligament. And this particular structure is very stiff, and when I do the surgery, that's one of the things that I'm taking out all the time. And I take this to the lab to start understanding, well, what's changing in this joint capsule? How do we prevent contractures from happening? And then we're just showing here the pre and post release. So this is a cartoon, kind of a busy cartoon, but this is kind of 10 to 15 years of research kind of distilled into one image. So, and what we think is causing the stiffness. In the brown, we'll start with the brown. This is collagen. So collagen is a protein that's normal in our tissues, and it's the tissue that gives the structure and the function to the joint capsule, to ligaments. Within this collagen, there are cells, and in these pink structures here we're representing as myofibroblasts. So fibroblasts are the normal cells, but we found in joint contractures that they've changed into cells that express muscle. So myo means muscle, so they're both fibroblasts and muscle cells. And they contract the collagen, they kind of glue it together, and it doesn't allow it to be as compliant as we'd like it to be. So it's stiffer, and the joint won't move as much. Now, within these cells, in the tissues, we've discovered that there's mast cells. So these are represented by these gray cells with the black granules in there. And they're important because they have growth factors. And when they release these growth factors, it can change the fibroblasts to these myofibroblasts. And then the final thing to kind of fill in the picture was we were looking at nerves, and there are nerves that are in the joint capsule. And there are certain types that have neuropeptides. And neuropeptides are special molecules that both signal impulses, but they can also work on inflammation. And how they work on inflammation is that they cause these mast cells to release their growth factors, and then these growth factors change the fibroblasts to myofibroblasts. So we're looking at the myofibroblast as being the effector cell. It's the thing that's changed. How it's changed is because the mast cells have released growth factors to induce these myofibroblasts. And why it has changed is because of the fracture, which causes pain, which causes the nerve impulses to come out and release these neuropeptides. So we've been working at this hypothesis as what's causing the changes in this capsule. And we've selected a medication called ketotifen. And ketotifen is a medication that prevents the mast cell from releasing its growth factors. And we've done some research in the lab suggesting that it would be an important way to maybe prevent the contractures. So we've now taken the, first a little bit about ketotifen. So ketotifen was first brought on the market to treat asthma. And this was over 40 years ago. So we've had over 40 years of use of ketotifen. And we've understood that it's a very safe medication in terms of side effects. It's a mast cell stabilizer, as I mentioned, but it also is an antihistamine. And one of the side effects of antihistamine is sedation. So that is what can be a side effect with the medication. Weight gain is the other more common side effect. It's about 1 or 2 kilograms if it's being used for about 16 weeks in some asthma trials. So with these as being the side effects, we've considered it to be mostly a pretty safe medication. And in fact, studies on overdose have shown that you can take 10 to 120 milligrams, so that's almost 120 times the recommended dose for asthma. And sedation is the most common effect. There's been no deaths reported with it. So we considered it a pretty safe medication to go forward. And it's also been used for over 40 years in humans. So we designed a study to look at the safety for this new indication. So it's been approved by the FDA and Health Canada for asthma, hasn't been approved for joint contractures or these elbow stiffness. So we started out with a safety study. We have been looking at it in adults who've had elbow fractures or dislocations, no previous stiffness in the elbow or contractures. And our research suggests that it has to start within about 7 days of the injury to be effective. So those are that's the basic population. We then took these people and we randomized them. So some got a intervention, some got a control. The intervention was the ketotifen, which they would take for 6 weeks. It's an oral medication. And then the control was using a lactose placebo or a sugar pill, so it didn't have any effective agent in it. And then we looked at the joint motion. We looked at the patient-reported outcomes, so that gets at some of the functional deficits that patients may have, and we were looking at fracture healing. And the picture on the bottom is actually one of the pills. So that's what the pill looks like, whether it's ketotifen or the placebo, so that the patient doesn't know what they're getting. I don't know what they're getting, and we're kind of blinded. And on the bottom here is a dime. This Canadian dime. I've also got a picture with an American dime that'll be important later. I'll tell you why. We're in Canada, though, so I had to show it with the Canadian dime. So we, in Calgary, we did this pilot study, and we randomized 152 participants into the study. And through this, we've finished it, and we've established that it's safe. So sedation was kind of similar, actually, between the two groups. Didn't really matter which one you were on, so that was interesting. Weight gain was actually a little bit less in the ketotifen group, but essentially the same. And so we've found out that it's a safe medication. So we've now gone on to the next step to do a multi-center trial. So we want to study, we need more patients, so we're looking at about 702, and we're going to do this across North America. We're going to limit it to more severe injuries, and we're looking at 2 different doses from ketotifen, and we were able to get funding from the U.S. Department of Defense, so I had to get one of those pictures with a U.S. dime so they'd understand the size of things. And we plan to start the project in 2018 in about April. So in summary, elbow stiffness is a significant problem after injuries. There are functional limitations, so when somebody can't straighten their elbow completely, they can't reach for objects. When you can't bend your elbow, get your hand to your face, it's difficult to do personal hygiene, so brush your teeth, comb your hair, all these things that we take for granted, grooming, dressing, and feeding. Our research has shown that mast cell stabilizer ketotifen has promise in this area, and we're working on clinical trials. We've established its safety here in Calgary, and now we're looking forward to do a definitive multi-center, multi-dose trial. So I'd like to thank you with that, and I'm going to ask